questions? Now we're good. Lenny Jason, DePaul University. The question I have has to do with kind of some of the issues that were brought up in the last presentation. I'm wondering if you might be willing to talk a little bit about patient selection and whether individuals who might have symptoms of this illness might differ in some of the different batches and samples, and whether that might have some implications for the different outcomes that have been found. And then kind of a second question that's a larger one that I'd like to throw to Nancy and Ron. And that has to do with kind of when we need to know something as being definitive. And I think of kind of one of the first epidemiologists, John Snow in Great Britain in the mid-1800s, found that there was a water supply that was getting people sick. And they didn't know about cholera, they didn't know about bacteria at that time, but what they did was they cut off the supply of water to a part of London and ended up taking care of that epidemic. So sometimes in the field of epidemiology, even though we might not know the specific kind of contributor to the epidemic, sometimes corrective actions can be taken that can have major public health implications. And I'm wondering if you might both be willing to comment on that and its possible relevance to the illness that we study.
Is this on? Yeah. As regards patient selection, I'm probably not the most qualified person to answer that, but I think I should say that at the XMRV workshop, this was an issue that was brought up, that patient selection with the studies that are just going forward now is also an important point. That's about as much as I can say to that question.
I'm answering that second question. I think that I always say that the things we know, they're the things we think we know, and the things that we still need to know. And so when I'm talking to my patients, I'll say just that. I said, I know this part. You know, I can treat blood pressure. There's been clinical trials with 10,000 people. But this is what I do know, and then this is what I think I know. So with chronic fatigue, I'd say that after all this many years of work, I know there's immune activation. I know there's immune dysregulation. I know there's pro-inflammatory cytokine expression in the sickest group. I know that the severity of the illness correlates with the severity of the immune disruption and the degree of inflammation. So in the spirit of turning off the contaminated wells of London, it would be reasonable to postulate immunomodulatory therapies that would either enhance antiviral function, if you're going down that thought, or to quiet but not completely shut down the pro-inflammatory cytokine cascade, like we do in rheumatoid arthritis or that sort of thing. And it's perfectly reasonable to postulate these types of studies and put them together for clinical trials work. And some of that has been done. There are some studies that have tried to do that and had seen some efficacy. We did a proof of concept years ago with expanded cytotoxic T cells. We took a lymph node from the patient, we took their cells out, we grew them, we made them really healthy, strong, robust, and antiviral, and we put them back in. And we got very significant responses in that phase 1 study, to the point where we shifted cytokine balance completely to a type 1 cytokine balance, shut off type 2 overexpression, reduced pro-inflammatory cytokines. The patients cognitively improved. We had some beautiful data on those 8 of 11 patients that responded to that therapy. It's proof of concept. You can shove the immune system hard in one direction and get another kind of clinical response. And it was more antiviral. So yes, I think that you could do that kind of intervention based on what we know so far. If we get to the point where we know which virus to downregulate, you know, we were very, all of us were actually feel kind of bad because we left Dr. John Chia's work out with the Coxsackie with the enterovirus. Enteroviruses are very important. Early in this game, Dr. Gow and others found or looked for enterovirus in muscle, a good place to look. They like to infect muscle. There's some initial positive reports, some follow-up negative reports, and sort of floated out, gone there for about a decade. And then Dr. Chia looked in the gut. His patients were, or he was seeing gut symptoms, so we looked in the gut. Beautiful, beautiful, beautiful stained photos of hundreds of patients with Coxsackie virus, type B viral reactivation in the gut. Moral of the story, it matters what compartment you look in, like the macaques. You know, where does the virus go? And, you know, you only know to look for what you think of to look for. There's a lot we don't know. And so if the immune system's gummed up enough that viruses reactivate, herpes family viruses are going to reactivate, and Coxsackie virus could reactivate. If we're talking about endogenous retroviruses versus infectious retroviruses, an activated immune system will kick out any kind of DNA it knows how to kick out, and that might include some viral stuff that's not whole virus, but is important and could regulate and muck up immune regulation. So there's a lot that could be done just by trying to quiet down that immune system.
I'm going to be more philosophical.
As you are.
I said at the beginning of my talk that we ain't so smart. And we're not. And I also said that we're dealing with three independent body systems that we forget to tell our medical students to put back in the body when we go through teaching them. And so they walk away with a concept that the immunology system, the immune system, the endocrine system, and so on, are separate systems. And I think the curricula at medical schools are just starting to recognize that that's the case, and hopefully that will, you know, open up a little bit different way of thinking. As a virologist who have collaborated with several people in this room on more than one study, I have this observation. And I recently had a telephone conversation with Susan Vernon about this. If you're a neurologist or an infectious disease doctor or a psychiatrist, your training has prepared you for your field of expertise. You think like a psychiatrist. You think like a psychologist, and so on. I mean, that's the way we're trained. So when you see a patient who walks in the door with chronic fatigue syndrome, or they think they have chronic fatigue syndrome, and they start out maybe somebody in family medicine, and then they get shunted over to a specialist. Each of those clinical people are looking at that patient from their perspective. It's a little like that elephant with blind people. Okay, they see something, or they may not see something, but it's within their context. You know, the easy diseases have been dealt with because they're fairly straightforward. The ones that ain't so easy are not so straightforward. So that's the starting point, is with somebody making a conclusion, a diagnosis based on their experiences. So when they participate in studies involving the preparation of the submission of serum samples to somebody like me to run for antibody markers, I'm getting the samples based on that person's bias and clinical diagnosis, which may or may not be right. What I do to those serum samples is much more specific, much more sensitive, much more objective than what the clinician has to deal with, because that's all they have to deal with. So one of the things I said to Susan, I said, gee, you know, actually I was at a meeting with Ben Nadelson. We were sitting around with his wife talking about this, and Ben, you know, he liked what I was basically proposing, was that there ought to be a group of people who have a lot of experience working with chronic fatigue syndrome patients, like Nance, who serve on this panel. And this panel gets serum samples from patients who are evaluated, not the serum samples, but the patients are evaluated by this panel, diagnosis. So here we have people collectively, one's a neurologist, one's an infectious disease person, one's a psychiatrist, and so on, at this table, each bringing their expertise with them to evaluate this patient. If a patient is evaluated as a legitimate CFS patient, that serum sample is taken, put in the freezer, and given to people like me or other laboratories as probably the best possible way of identifying the closest, reasonably accurate reflective of chronic fatigue syndrome. That gives me, I said for garbage in, garbage out. I can only present data to my colleagues based on the serum samples that they send me. So what I need the best serum samples, and we need to have the best way of getting those serum samples so we know for sure that we can say, if this is, it's a little like we were talking about with the retrovirus, if this is negative, this is the best shot we have to say it's negative. If this is positive, this is the best shot we have to say it's positive. Now people like me can do some science.